All right, last speaker before you guys best to speed through a little bit some of the things I wanted to share with you and that I had a chance to talk with Aki about. And real quick before I begin, just a quick disclosure statement. I am a consultant for the Department of Defense's Murtha Cancer Center through their Henry Jackson Foundation. And one of the things when Aki called me up and actually she faced, hey, we're having this event, would you be willing to come and talk about research participation? So for those that don't know, always serving the director of the Cancer Institute for 10 months, had the real privilege of serving in research for the Cancer Moonshot. You have heard of the Cancer Moonshot. It was just interesting for me to come from living on the East Coast for so long, and everybody was really excited about it there, and the scientists, physicians sort of heard about the Cancer Moonshot. At the last State of the Union that former President Obama gave, he charged former Vice President Biden to launch a Cancer Moonshot, to bring together all the different federal agencies and public sectors and private sectors, and start a task force to figure out how we might actually make leaps in this disease rather than incremental advances. And I'm sure this will not do well on the YouTube in a few years. However, I am not here to help. This is not a political reference to the former president. More for you guys to just how much passion he had for this particular disease. Hello? Whoa. Okay. Well, everyone's awake now. I think from my perspective, all of you can participate in these 4 or 5 pillars of research. And for those of you that are not former NIH folks, we tend to think about translation in 2 buckets. Translation from basic science to human studies, T0 to T2, and then T3, T4, translation of new interventions into clinical and health decision making. And all of you can participate in T0, T1, T2, T3, T4, from clinical trials to outcome-based to population science. This is where all of you can have an impact. And I know this because for 8 years, I served as a scientist mentor for a program that's been around for about 20 years now called the Scientist Survivorship Program for the American Association for Cancer Research. And through that program, had the privilege of leading teams that come to this annual meeting with about 10,000 scientists and help them navigate these different sectors of science at this AACR meeting. And each one of them taught me something different. For me, I'm a chemical engineer by training. So learning exactly what is wrong with the ecosystem is something an engineer loves to do. We try to figure out how to fix those types of hiccups and problems. And of course, as I listen to each one of these teams, they all have to give a presentation after their 4 days at AACR. And I'm always astonished that, having never been to a scientific conference, that the final summary that they give on topics like genomics in 2014, cancer complexity in 2016, and even omics in 2017, they do a better job than some of my former staff members at NCI on summarizing the crisp points of what might be changing the cancer landscape. And of course, also in 2017 was a chance for me to meet Aki through this particular program. And again, coming back here to help for this particular effort was just a no-brainer. But looking at your organization and your website, I'm excited to see that there are resources that you have to think about T0 to T2 research, from doing germline type work, cancer profiling work, as well as how to find clinical trials. I think this particular organization does a great job looking at sort of T0 to T2. Where I push you guys a little bit is, how do we do a little bit more of that T3, T4? And the next 2 slides I actually used to sort of give former Vice President Biden and his team, when I joined March of 2016, a general context of what's it been like pushing these type of programs for 10 years at the Cancer Institute. And one of my biggest issues as an engineer is that we hear a lot about precision health efforts. So you go and you send and do your 23andMe Maybe you'll give a little bit of data, but you have a lot of people doing that. And you'll understand a little bit about predispositions and health. And then, of course, we heard this morning about precision oncology efforts, where we get a lot of data on a few patients. And as an engineer, I love to look at state changes, right? How does this work? We talk a lot about precision health to precision oncology. We don't do as much talking about what does this mean coming back the other way. And most importantly, it's not a two-state system. Right? We heard a lot about this throughout the day. Morbidities, multimorbidities. It isn't just you're healthy, you're not healthy. You're not healthy, you're healthy. So for me, being at the Cancer Institute for 10 years, this was sort of an engineer's dream. How do we develop a continuum? How do I understand what your primary disease is, your local disease, and then your metastatic disease? How do I understand you in those in-between time points? That's just something that I always assumed, having joined the Cancer Institute as an engineer, already existed. And surprising to me, in 2006, it did not. And I will say a lot of what I'll talk about, I really had a pleasure of sitting with 22 other of my colleagues, our leadership at the Cancer Institute every Tuesday. I got to review every single grant that came in, every type of science. It was really a great way for me to better understand some of the different facets of funding this disease, of the science that was going on in this domain, especially, again, coming from somebody that's trained formally as a chemical engineer. And the organization that I had the pleasure of leading for 13 years was actually one that served 6, although I cheat a little bit, all the different NCI directors that are all presidentially appointed. And when I refer to my former boss, Ned, I mean Ned Sharpless, not NED, some of the things that you guys have been talking about today as well. But this organization, I'm really proud of because we really pushed the envelope. We really wanted to be able to get data sets, infrastructures, and deploy them to empower the entire cancer research continuum, that T0 all the way out to T4. Not just basic science, not just therapeutic development, not just clinical trials. And for me, it was very important that all the things that we were building that were sort of 5 to 10 years out from being useful, hopefully, to our physicians in the room, that they were all used for, that we were all very focused on patient benefit. And when I got the phone call in March of 2016 to join former Vice President's team, I was very shocked because usually my organization, nobody's heard of. And we do it that way because we receive 3% of the NCI budget and we report directly to director. So my boss at that time, Doug Lowy, said that I had been found. And again, just explaining to him exactly what the state of the science was and how come we needed something like the moonshot, which had 3 very simple goals. And as you can imagine, my former organization really helped me sort of push the envelope on enhanced data sharing, greater cooperation between different sectors. And I was very surprised at how many people came to help from the different federal agencies. So it wasn't just the Cancer Institute, and it wasn't just Department of Defense, but even our US Patent Office had something that they could streamline. Of course, our Center for Medicaid and Medicare Services had something to streamline. Our VA, our National Science Foundation, our very first chief data scientist, DJ Patel, all of them came together and said, how do we fix this ecosystem? How do we do better? And what were we all trying to do? What we were trying to do is create some form of a learning healthcare system in the United States where we could take the contributed knowledge and experience of every cancer patient to enhance, improve, and inform the journey of hopefully as many cancer patients as possible from the point of diagnosis to survivorship. And of course, this is very DC, very lofty, and all that we were truly trying to do was make data fair and transparent. Make it findable, accessible, interoperable, most importantly, reusable. And you would wonder, why would you need to do this, right? All the data is publicly available. People can actually get that data, right? And how many people here have had to request your data transferred from one institution to another? How many people enjoy that process? And this is 2019, right? And the reusable part was one that I think was the most difficult sometimes to think through. So I'll just use a quick example. So for me on my iPhone, I have my data of my pictures that I've taken. my iPhone decides that this person is very different than, 20-year-old Jerry, and glasses Jerry and sunglasses Jerry. So sure, we can have some AI on that local data. And there's some reuse there. Thankfully, for me, those of you that know me, I'm quite a social media junkie. Many, many years ago, I chose to upload both my data to Instagram and to Facebook. Now, I didn't anticipate Facebook coming out with a feature called Memories, but if I had not uploaded it both to database A and database B, I would miss out on this feature. So as you think about giving up your data, what types of things that we might not even imagine yet that your data might be helping, make sure to contribute it to as many places as you can. And that way, this might be a way for future reuse of your data sets. Probably the most proud data set that my team had a chance to build out, we thought it was totally impossible to do for 8 years, was taking primary, untreated, late-stage tumors and conducting molecular profile at scale. Some of you might know that as the Cancer Genome Atlas. For me, when I joined in July of 2006, everybody told me that we would try this project, and then I saw this Science paper that came out 2 months after that and said, in 2006, the largest data set that was available was 22 patients, 11 colon, 11 breast. And I have to do this orientation each time, and especially with former Vice President Biden, because he thought that we had been sequencing for decades. This was the sense of scale back then. And finding 189 cancer genes in 2006 was a treasure trove. And for many of you that are skeptical that the moonshot was going to do anything, I would say this was some of the things that I felt reading this particular paper, because this particular study was done by Eli Lilly and Johns Hopkins, and it cost them $20 million to do back in 2006. And for the Cancer Genome Atlas, we were given a whopping $100 million to do 600 cases, not 22, but 600. So how did we get that done? And I'm going to spare you some of those details, but I'm really proud of our team. When we first started, we started with a brain disease called glioblastoma multiforme, moved on to ovarian. And this is what the Cancer Genome Atlas looked like in 2008, 2009. Each row, one patient, each column 1 through 23. And you can definitely see some of the heterogeneity that was mentioned this morning. I was so proud that we got this particular pilot off the ground. We presented it to our board in 2009 and said, let's do 7 more, so we'd have 10 tumor types. And then my former boss, Anna Barker, stopped at my door and said, actually, there's this new administration coming along. They want to do something big. They want to give some stimulus money. They want us to turn this atlas from 10 tumor types to 25 tumor types in 2 years. Now, I'm a pretty decent engineer, but that was definitely, I did not sleep at all from 2009 to 2011, because as you can notice, that projected line versus the reality line that we gave the former administration, it was many of the patients that were willing to donate their samples that made this happen. I was there certainly to sign off on all of that and to coordinate all of that, but without your participation, that wouldn't have happened. What does Atlas look like now? There's 25 tumor types. Again, each row, one patient, column 1 through 23. And you can actually see all of these diseases just are a little bit different than each other. And this is the type of atlas that we made publicly available in 2014, high quality data so that others could reuse that data for other purposes. What did we do with that data? Of course, some of you may have seen and heard about the NCI MATCH trial. We took some of those very complicated signatures, simplified it to 143 genes, subjected those to cancers where standard treatment no longer responded. 6,000 patients later, we're about 18%. So that, again, this morning, people talked a little bit about just where the genome got us and where we need to move beyond that. Well, thankfully, my office, we always did the pilots that nobody else wanted to do, because in 2011, we started a very small pilot to think about going beyond the genome, doing some proteomics with those same samples. And everybody told us that was also impossible. So we took 375 cases from TCGA and did concurrent genomics and proteomics, just another type of profiling that you heard this morning, on the same patient sample, not similar ones, but that same patient. We weren't sure what we were going to get out of it, but we were very excited to see that through this concurrent profiling, we actually picked up an additional 66% of the information that the genome alone didn't tell us. But where I was in 2016, I was not satisfied that we were, of course, successful with our genome program, our proteomics program, as well as our match program, because we never were able to get to that other side. We develop all of these therapies. How do we know if it's changing clinical healthcare decision-making? And this is a space that is not traditionally funded by the Cancer Institute, nor by the NIH. This divide I put here intentionally. There are organizations like AHRQ, PCORI. Some of you might be participating in those that have that mandate, but this is not an NIH mandate. So it was great when you have somebody like former Vice President Biden tell the other federal agencies to actually work together. And what he said to me the first time that we met, he said, I was told by somebody that you did this thing called the Genome Atlas. I don't know what it is. And then you did this proteomics thing. Could you, through our moonshot, actually take this sort of very slow trajectory of proteogenomics data, and could you make a signature initiative for me? And what I ended up letting him know is this sort of, how do we make data fair? So I was very excited that he, in June of 2016, helped us launch the Cancer Institute's Genomic Data Commons, where we took all of this genomic data, where it's very difficult to use, and placed it in a domain where it was a little bit easier for computational scientists to use. And how do we know that? Well, between June 6 of 2016 and December of 2016, there were 8 million downloads worldwide of these data sets. I will tell you, there will be no amount of NCI outreach that would have gotten 8 million people to look at these data sets. And that's 8 million more eyes to find more innovations. And it wasn't just the federal sector. Foundation Medicine, we were very excited on that same day, donated 18,000 patients worth of data into the Genomic Data Commons. And it just kept moving. And this was, of course, after the administration was turned over. Other studies like the AACR Genie study, Multiple Myeloma Research Foundation, and other places are starting to deposit these data sets into the Genomic Data Commons so everybody could start reusing these data and innovating with these data. This final program down here is the one that we did build for former Vice President Biden. It's a program called the Apollo program with the VA and the DoD. And we did that, and why we went to the VA and the DoD was because even though we did the Genome Atlas and our match program, I still don't have any knowledge of how the patient was doing in between those two time points. And some of that, of course, is attributed to the fact that in the United States, no matter how great your cancer center is, 85% of cancer patients are first seen, first diagnosed, first treated in community cancer centers. And how do we get to that 85%? That was something that former Vice President Biden was very passionate about. He said, I didn't know that. And how do we actually connect this data ecosystem? Because in the United States, we do have a mildly fragmented system. But there's actually two places where it's not. Department of Veterans Affairs, Department of Defense. Those two systems are connected. So I was very excited to launch with Department of Defense's first Cancer Center Director, Colonel Craig Shriver, a surgeon, a program called the Apollo program, where there was commitment from the Cancer Institute, Department of Defense, and Veterans Affairs to start a longitudinal trial, prospective trial, to be able to collect outcomes and information on 8,000 patients across these two ecosystems, and most importantly, get that information out into public domain. For those that don't want to look at this wiring diagram, I'll simplify it. Through that particular effort, we are now being able to connect and better understand what's happening in between those treatments. How else could we advance the T3 to T4? And the part that I really appreciate from him, he took that playbook and went international and asked Australia if Australia would follow our playbook and donate data sets that they were generating on 60,000 patients in Australia. And Australia said yes. And I thought that this was just some White House, great term that people use, and perhaps it was just a feel-good sentence. And what I didn't realize when I came back, and when he came back from Australia, on my desk it said, could we do this for another 9 countries? And for me, I just love these type of challenges. So it was great. In a few months, we were able to coordinate with 9 other countries and 9 other countries worldwide, including Korea, Taiwan, Japan, the UK, Canada. They are also following that playbook. They are also donating those data sets back into our ecosystem. And I don't want to just give credit to Defense and to NCI and to the VA, Department of Energy, because one of the things that I saw firsthand, we had to send terabyte drives in 2010 during the Cancer Genome Atlas, because that was the fastest way to send a terabyte of data. Put a drive in a FedEx box and send it. Right? That's 2010. So being able to leverage the fact that Department of Energy has supercomputers that are connected with each other, how could we bring people into that data set? That's really the important part. We don't want to generate more silos. The other part that we push forward, the NCI and the VA also put together a program called Navigate. How do we bring more people into clinical trials, especially from some of those lower socioeconomic, the community cancer type settings? How do we really reach out and engage them? And last but certainly not least, the Food and Drug Administration. One of the pilots that came out of the Cancer Moonshot is an entity called the FDA's Oncology Center of Excellence. And the reason that this is important from my perspective and what you heard this morning from the other speakers, in the past, if somebody wanted to go in and have a device or a biologic like your antibodies or your checkpoint or a drug approved, you'd have to go to FDA 3 different times. Through the Oncology Center of Excellence, we're hoping that process is once. You can go to the FDA with a device and a biologic. When you hear about combinations and you want a small molecule biologic and some kind of companion diagnostic, that to me is what Rick and his team are dedicated to do. Also really excited to watch as OCE continues to mature. And again, these are courtesy of the Deputy Director, Gidon Blumenthal, a great friend and a collaborator. All the things that OCA has been able to do, and some of the presenter this morning had a chance to talk about new drug approvals across different cancer types. That's being pushed along. And I'm glad to see, and not glad to see, the FDA, like myself in the past, we still have some issues pushing into that T3, T4 domain. How do we get real world data? How do we get decentralized clinical trials, more pragmatic clinical trials? How do we generate what we refer to as patient journey lines? And not just their cancer journey, but any of their comorbidities, and if they are moving. How do we make this more seamless? So the one part of the 21st Century Cures Act, an outcome of the Cancer Moonshot, this law, I think everybody knows it because it gave some money to enable the Cancer Moonshot precision medicine. If there's a way to sort of really appreciate one part of a law, I would say this is my favorite part of the 21st Century Cures Act. How do we get to a point where we can promote patient access in a single longitudinal format that is easy to understand, secure, and updated automatically? How many of you would want that? Right? If you've not heard of the 21st Century Cures Act, it is law. It is not appropriation. And I'm really excited to see, and trying to stay not partisan, the current administration has in fact pushed to try to better implement what this component of the 21st Century Cures Act. How do we get to a point when we can move our data sets and have this happen? And for those of you that don't quite get it, I just have 2 little kiddos, and I assume many of you have bought movies on VCR tape, had to rebuy those movies on DVDs over the years. And then you got this little insert in your Blu-ray and your DVD, and then you could redeem that. But if you bought it on iTunes, you couldn't bring it over to your other ecosystems. This is the type of thing that, of course, something like Movie Anywhere, I don't know how many of you guys use this, allow one company to go through Movie Anywhere and say, hey, did I buy that movie already? If I did, can I have it on my other accounts? And the most important part of this particular example is connector eligible. In the case of your data, who's going to determine that? You, right? So as you think about this new ecosystem of connected datas, of databases, of molecular profiling, don't forget that permission is the most important thing. And definitely read your terms of services, your consent form. You don't want to be getting your free Wi-Fi and then signing away your firstborn. Understand the type of studies that you are going to participate in. And I'll just wrap up here and say, in addition to the things that I did do, one of the things I'm excited about doing here now at the USC and the Larry J. Ellison Institute for Transformative Medicine, we are continuing to work with Craig Shriver. We put out this paper a couple of weeks ago in which how we will build this learning healthcare system with the VA and the DoD is in the article. How we will make those data sets, the longitudinal tracked data sets, the patient outcomes, and also some of the non-cancer associated data sets, how will we put them out in the public domain? How will we have people come in and access those data sets? I think that's important. Another thing that I wish I had time during the moonshot to help fix is the fact that many of you do certainly see cancer statistics cited every year through our NCI SEER program, in which we look at incidence over time. That data is always a little bit slower, not because people aren't collecting it, but that type of science is just a little bit slower than others. But we always want to, we're always hoping, and we're hoping that this is what that future trajectory looks like, but we have no way to actually know that. So I'm really excited, and I didn't know this, but that's not why I chose USC, but I'm glad that I'm at USC in this particular resource. USC has been home to probably one of the oldest programs that report into the NCI SEER program led by Dennis Deepin currently. And we're working with them as well as with colleagues like Injin that many of you may know, and she's been teaching me a little bit about stomach cancer over the past year that I've been at USC. How do we sort of shorten that time frame? How do we now think about proteogenomics and not just genomics? And how do we think about these longitudinal data sets being collected? And we're still not doing this in isolation, and I apologize for the slides being a little bit delayed, but 2 days ago we actually had a second visit with FDA, with Gignan, to sort of let him know what we've been building with DoD and VA. Is that still something that the FDA could use? And they were very excited about that process. And for the 2 Air Force members that I met this morning, this one I added just for you. Actually, yesterday, we had a chance to visit again with our surgical colleagues at Department of Defense. We're going to run some more pilot studies with them. And these are some of the things that I'm really excited that we're doing now. But I don't want to forget the purpose of my presentation. It's all of you and all the permissions that you provide to allow us to analyze your data sets, and for the caregivers in the room, for those of you that are helping to think about where those data sets might be. Everybody that comes and talks to me about TCGA now tell me it's great data sets. I always remind them it's 10,000 patients worth of wishes. And that's something that I'm really excited to continue to work with you guys or others so that we can someday have this type of a research ecosystem for everyone. So if you have any questions, please feel free to send me an email. And for actually the morning speaker, I actually added this as well. I really want to thank all the patient advocates, research participants that have really enabled some of the things that we've had a chance to build. So thank you.